or even a heart rate less than 60, and we've now decided to give meds, that dosing changes. In fact, it goes up. Pause for shock. Right?
Because they gotta get the zooms and hearts.
It's a double entendre, pause for shock. But I don't know what to tell you. My assumption, pretty simply, is that the children are not very good at responding to anticholinergics. Do we know any anticholinergics?
I don't remember, to be honest.
We do know one.
It's been a minute since I
Find it.
Cholinergic, anticholinergic. It's I know it's, where are you at? You're somewhere.
That be the Atropine?
You got it.
That's what it was, because I knew it was either albuterol or ethanol.
It's part of the reason why we don't administer Atrovent very often to pediatrics. You guys probably don't know that, but it's not very common in the field, and it's simply because the younger we are, the less they seem to respond very well to cholinergic responses. They are, however, very receptive to adrenergic responses, and maybe that's why neonates essentially require the double dose of peds. To be honest, I don't know.
I think their heart rate's supposed to be like double.
True.
Maybe, and so maybe they're just like, they just need more. But what would be interesting here is, yeah, maybe it's just that simple. It's just we want to give more effect. Could be. I don't know. Either way, so we're not going to run through this right now because it's a little bit harder math, I guess technically, than say just 0.1 or whatnot. But you should know, like, here's a baby come out, they're bagging, and they're like, yo, we need epi. And so you're going to have to be so good at drawing up epi and understanding the formulas that you can do it while somebody's working a 32-year-old or 6-month-old baby that died in their crib, and now you have to do the med on this stuff, right? What that means is that if you're in scenarios, now it's going to be a little harder for you to kind of sneak around or whatnot if you don't know these things, because a lot of our labs are just going to be 2-man labs, where it'll be either you know it or your partner knows it, right? So, however, if right now, or I wouldn't say now, but certainly after Tuesday, if you're like, oh Jesus, please don't be a neonate, please, oh, it's a neonate, if that's where you're at, you have messed up. You need to be doing more at home. You need to be like, all right, 1-month-old, 2-month-old, 3-month-old, 4-month-old, and go through it over and over and over. Now, I'll do some, but I don't have any homework for this class. Everything I give you for homework is stuff I'm creating on the spot. Now, my goal is to be the year of the homework, where every lab is a packet that if you don't finish it, and I'll make it long enough that you hopefully don't finish it, have to take it home and have to do it. But much like Destiny, very gratefully, saying, hey, can you just kind of give me some sample stuff? I'm like, I will try, but it's all first-year creation for me, which means if it's still foreign to you and what I have given you isn't enough, then you need to do your own work there. You need to say, all right, let's just, maybe I have some labs that's like, hey, go through every month and the dosing for that month. Boom, that's the lab. For 20, 30 minutes, that's the lab. Or whatever. It's going to be stuff like that. Because you, again, right, it's like the invader shot percentage. If you're hitting the bullseye 100% of the time under stress, what happens when the baby freshly pops out and now you have to do the math? Are you so good at it that your margin of error is low? And if you're thinking to yourself, oh, Jesus, well, I'll probably be with a medic and hopefully they know, that is wrong. It's in your scope now, which means if he gets it wrong, so do you. I say that because only boys are medics. It's just a thing.
Speaking of which, is there kind of like the same thing for like neonates for like weight-based, kind of like there is for peds?
Do you mean a hand-heavy shortcut?
Yeah, or is there like
No.
something like that, or like, so like how do you know like the
Guesstimate. I mean, they're not going to know because if we're talking about a newborn, then you don't know.
Okay.
If we're talking about a newborn, what we're really kind of looking at is conversation about term, meaning like if it's full term and I'm looking at it, but it pulls on anecdotal evidence because they come out and you're like, this feels like a heavy baby. I don't know a shortcut outside of Broslow tape. The Broslow tape is a extended, it's a piece of paper that unfolds like the length of my arms, and you lay a baby on it, and wherever they line up is their weight. So the answer to your question about neonate would be, I put this little baby on this tape, Broslow tape, and I say, oh, okay, they're 21 inches, that means they're about 8 kilograms or whatever the case is. Well, there'd be 8 pounds probably, so it's around 4 kilograms, but that's the answer to your question. So, Broslow tape. Otherwise, it's like, well, this looks like a big baby, I'm just gonna go ahead and go.
Yeah, because I was like, wait a minute.
Remember earlier when you mentioned something, you're like, my idea, don't steal it. They should make the stretchers be a scale.
That's a good idea, yeah.
That automatically converts to.
Sure, it couldn't work, it would have to have an adapter for neonates, because they're so small, but no, that's a great idea. It's a great idea.
Looking at it.
Exactly.
Alright, now here's the new world that we live in. You might exist, and in fact, you will have test questions and scenarios where when you walk in and you say, okay, my patient is in cardiac arrest, what medication do we want to give?
1 to 10,000.
Full name, right? First and last name, epi, 1 to 10,000. Great. And so you say, I'm going to go ahead and give epi 1 to 10,000. So your adjunct will say, great, what's your dose? And you'll say, well, it's pediatric at such and such weight. He says, great. Please give me your 1 to 10. You don't have 1 to 10. So now what do you give? You still want to give 1 to 10,000, but now you have to make it. How do you make it? Well, it's simple. If I want to make 1 to 10,000, all I'm doing is pushing a milliliter out of a saline flush. So here's my 10 milliliters. I push out a milliliter, and then I draw up a milliliter of 1 to 1,000, shake it, now I have 1 to 10,000.
Oh.
So I have for you blunt needles, which are harder to push into the vials, but you can't stab yourself, so that's why we're going to do that. So I'm going to hand these out. These are blunt needles. What we'll need to do is find our 1 to 1,000 epi, or adrenaline as it's listed. You'll need to start by pushing out 1 milliliter out of your saline flush so that you have 9 milliliters of saline. You'll need to push in your needle and withdraw that. Now I'll talk about how to do it after you've done it once, but I just want to kind of see what you'll do here. Pop it like the movies. Tarnation!
You didn't see the fireworks come out?
No, dude. I felt the heat though.
Be down.
I felt pheromones.
What are we doing? Look at that.
You are making
What's
1
happening?
to 10,000. And since you have, go ahead.
Wait, no. Just stop talking. What happened?
Because she started talking, and I think you teach each other much better than I do. So give it a try.
Right. Plus 9 milliliters. Oh, okay. So she 9 milliliters.
Oh, you right.
No, you're able.
Okay.
Draw it up here, that way you can push that one in.
Like even if there's.
Yes, because we need to bring our air
But,
So you're in a
but
Oh,
sometimes I build groups around like,
to draw it up.
I see that you like make sure you get like the.
Oh, okay, because we didn't have space.
you're one of the only two that I have animosity jokes back and forth with, whereas everybody else it's all edifying, but you two like seem to only like what hurts you, so here we are. I get it. Yeah, it's pinging. Did you put it in yourself? Don't do that.
Yeah.
You are.
Yeah.
Well, the vacuum existed before. You have to counteract that with that.
We're losing steam, that's what we're doing.
Sure, which is okay. I
You
plan.
got the big.
In fact, that's actually just.
Did he say?
Okay, gang. So let's take a break here. I want to walk through some steps here, or at least how I wanted you to kind of be exposed to it before I told you how I do it, right? So let's say that essentially this is a flush. I pull it out of the packaging. I get off the cap here. And then I'm just gonna make sure that if there's any bubbles there, just a quick tap if I can. I don't care if it stays, just a quick tap. And then I push the air out to see what is left. Now in this case, I only have 8, but let's assume currently that I've pushed out 1 milliliter and left me with 9. Now what I want to do is I say, okay, well I'm gonna find my adrenaline, right dose, right time, all these kind of things. This is adrenaline 1 to 1. Now what I wanna do is I need to get this in here, right? So what I'm going to do is I'm going to attach my needle and pull off the casing of it. What I want to do actually is how much of this do I want? How much 1 to 1,000 epi do I want in this?
1 milliliter.
1 milligram or 1 milliliter. So what I'm going to do then is draw up a milliliter of air. because much like Peyton said, there's a vacuum occurring here that will pull against you, and I almost want to counteract that. So now I'm going to push this needle in, and I'm going to push in what I want to take out. I'm going to push in a milliliter of air, give or take, and now I just let go, it'll draw itself out. Because you want to push in the air of the liquid you want to withdraw. So if I wanted 2 milliliters, how much air would I push in? See what I'm saying? Okay. Now, as far as the mechanics of this, I do what we call wrist to forearm, or wrist to wrist actually, because when you're bouncing down the road, when you move, you want your hands to move together so you're less likely to stab yourself, right? And so when I'm doing this stuff, I'm always kind of pinning, right? Like, despite how amazing it looks to shoot a gun way out here, it's way better to stabilize yourself or use a bipod or some kind of thing. And in fact, it's what they call the Weber position. I didn't get any chicks with this, but you will kill people. So, I don't know, depends on what side you want to get in on. In fact, if you notice, like, what do the special forces guys do? They got the MP5s. Like, this looks super dorky, but when you're moving, it looks exactly how they look, right? That's that position. The point is you need to stabilize yourself, or else you might poke yourself. You shouldn't go in it like this. I do wrist to wrist, right? So I'll stick in just like that. Okay? So I push in my 1 milliliter, I draw out my 1 milliliter, I now have 1 milliliter of 1 to 1,000 in 9 milliliters, or a 10 milliliter solution with 1 milligram, I now have 1 to 10,000. Okay?
It looks murky.
So basically, this should be empty, right? It's 1
Yes.
milliliter in there, okay.
I had to check concentration.
Like,
It's a
tight.
long-
That one was like decent.
So that's that.
Some air.
Okay. Now, the short answer, here's one thing I would say. On registry, everyone, I'm going to say this, you say it back. You never cap needles. Never recap needles.
Never recap needles.
It used to be auto-fail. The language is tricky now, but here's what I'll say. Never recap needles. Or if you must,
Do the one.
you do it one-handed, right? Which is, if you must, you don't, I mean, you just scoop it up. But I recommend you never do that. Did I do it 1,000 times in the field? Well, of course, I'm not an idiot. But it used to be auto-fail, so be careful with that stuff. In fact, one of the things I would commonly do is if I wanted to remove this needle, I am not teaching you this, okay? So don't pay attention or remember what I'm saying here, okay? Is that I would just bend it and then turn it like a faucet to take it off. Because sometimes they get so tight on there, you're like, ugh, trying to pinch, tweak. I just bent it, now it's a handle. I am not teaching you that. It might be very dangerous in registry to do something like that. Did I do it for years and years and years and years? Yeah, because I'm a genius. But you shouldn't. Okay? It's not technically your fault, I guess. I'll let you know if you need it. Don't recap needles. And when you reveal a sharp, and we'll do this on Tuesday, but when you reveal a sharp, it goes before anything. I don't care if CPR is happening. I don't care if you need a life-saving intervention. It goes in the sharps, or else you fail. If you reveal a sharp, it goes in the sharps, not the garbage, instantly and immediately. Even if your partner is like, wait, I want to marry you. It's like, no, you must wait.
Nope, sharps.
Sharps.
Yeah.
Can you repeat you're doing what with this?
You're talking about drawing it up?
Yeah.
Okay, let's just do this. If you were the one that drew it up, let's have the other person now do it, okay? So make me, assuming you have 9 milliliters, or sorry, let's assume that this thing is full. I want you to draw up 1 milliliter of 1 to 1,000. Okay? And so you're asking me how to do that?
Yeah.
Okay, great. Let's assume, is this still 10 milliliters?
It's 9, but I drew
It's
that
9.
till.
Great. So you drew the air that you wanted. Now you want to inject that air into the bottle.
A milliliter. So go back to the.
Have fun with that.
And it might, because it might already have too much in it. And that's okay.
Right.
Very good. Okay, so let's try to inject 1 milliliter. If it fights you really hard, then it's already got what it needs. Okay, you push in your 1 milliliter of air, correct?
Hopefully I did that right.
Wrist to wrist.
And then you want to withdraw 1 milliliter. Now, you should know, if you notice, we're all holding this upside down. Why is that?
That way it covers the needles.
Honestly, there's no reason for that. It's just what we do. It's how we see it. Everybody's used to drawing down, right? The truth is, do whatever's comfortable, really. Mostly I'm trying to get you to avoid stabbing yourself and when you're bouncing down the road. And I personally just wrist to wrist.
There you go.
Maybe. Yeah, some people do forearms, but
Cause I'm just used to it like being upside down. That way
Does
I
it
don't
work?
really have to like
yeah, I don't know.
worry about it like going up.
Oh, I see.
Oh.
Boom. I mean, you still look dorky, but you're also not stabbing yourself. Like I'm telling you, dude, this stuff will correct itself. You'll be like, jab, ouch, how do I not do that again? Now, I do a couple of things here, gang. I do, like, when I'm doing it, admittedly, I do it upside down. Dude, you hand me that? I tried to space it out, but, right? So I'll say this. What I don't do is I don't, like, this is often how I do it, is I hold my syringes like this, right? And so here I am bracing myself, I puncture it in, and now all I have to do is draw back on my thumb, but whatever works, right? Also, here's part of the point I'm making. If you do it upside down, which is okay, you have to make sure that that needle is still in the liquid and therefore barely at the edge. If you do it right side up, you can just push it until it clicks. Now you don't have to look at it. It doesn't matter that it's upside down. What matters is you're drawing up the med, not the air. So however you do that, whether you set it like this and push it down or turn it upside down like because you're in ER in the movies and stuff, like whatever works. But if you do it upside down, you have to make sure that the needle is just barely in there so you're not drawing up a bunch of air. Or turn it upside down, wait for the click, and then you can draw up all the meds yourself. It's up to you. You know what I mean?
Oh, thank you for that.
It's a gift. Tina, did that? You got it? Or
Yeah.
Okay, good. So, epi, what goes, when we're talking about epinephrine, which one is IV epi, which one is other epi?
1,000 is other epi. 1 to 10,000 is.
Sorry, say IV is what?
1 to 10,000.
1 to 10,000, right? We need it more diluted, you know?
Yep. And then 1 to 1,000 is
The lie.
everything else. Did you have to?
Now, you can give it every 3 to 5 minutes. Why do I choose to give cardiac epi every 4 minutes? 2 cycles of CPR, very good. Breathe, breathe, epi time.
We got drones.
So it somewhat complicates or adds more onto.
Every time. They're gonna be like, they are.
To our cardiac arrest rhythm.
Ooh.
This is the rhythm you already know, plus epi every 4 minutes. What this means is you're sitting there, you go up, you want to attach the monitor to defibrillator, is my rhythm shockable, blah, blah, blah. Now this is the ACLS algorithm, but it's the only one that includes medication and shocking. What this means is every 2 minutes, the AED is going to check. You're going to be doing CPR, and it'll say, analyzing rhythm, stop CPR. It does that every 2 minutes. While it's doing that, essentially, you don't want to touch the patient, but that will be essentially not the first time, but the second time you'll be giving epi every 4 minutes. So you can, I wrote, here's it in pictures, here's it in words, or here's it in its simplest form. The second time the AED tells you to analyze is when you should be giving epi. Because it will check every 2 minutes, so every second time will be 4 minutes, which means epi. The question would then be, when do you stop giving epi? If you're giving it every 4 minutes, how much are you giving in total? Well, whatever the math works out onto the 20 minutes or 30 minutes that you're working it, that you stop. Do you remember what I used to say as far as if your patient is in cardiac arrest as an EMT, we are advocating for transport, right? Because you just didn't have access to it, access to medications. Now you do.
Pump blood drugs.
So you would want transport more, even though you don't have like atropine or.
Asterisks. There are medications that are not in your scope for dysrhythmias. We give epi in every cardiac arrest rhythm. Asystole, VTAC, VFib, PEA, doesn't matter. It all gets epi. It's the same everywhere. But there are some cardiac arrest rhythms that require dysrhythmics, like amiodarone, lidocaine, and so forth. So there's a world there where now you're using monitors, right? Whereas if you are in a VFib arrest or a VTAC arrest, where I'm teaching you at some point, no, you better transport, you need to get to where there's amiodarone, you need to get to where there's all these other things. So now we're gonna have to start differentiating, wait, what kind of dead are they? Because that determines whether or not I leave. We're gonna know all that later. But for now, remember that cardiac arrest algorithm you know, which is to do CPR every 2 minute blocks, wait for the AED to prompt you. All we're doing is adding epi to that every 4 minutes until you stop. It might mean that you end up giving 6, 7 epi, or whatever the case. Sky's the limit until their heart stops. Now, let me ask you this. If we are giving it for anaphylaxis, why are we even giving epi and cardiac arrest in the first place? What's the point?
It's adrenaline.
It's
Adrenaline.
yeah, baby.
Get the heart going.
Here's what we are finding. A lot of articles are coming out that is saying epi is proven to decrease cardiac arrest. It's proven to help. Would you be surprised to learn that if I walk over and I strap your heart to a car battery, that will also give you a rhythm?
Mhm.
The problem is that we're finding that epi isn't super good at returning people's brains. I mean, if I give you liquid lightning, it will sometimes return your heart rate, but it is not often returning you to normal life. And it puts us in an interesting discussion about, well, if this isn't returning people to normal life, but it is returning heart rates, should we be doing it? And I would argue that's not your decision to make.
Is that dependent on their time without,
On their what?
like on their time without like oxygen and stuff? Or, like,
It's
heart rate?
dependent on a lot of factors: age, time without CPR, time without oxygenation, Kaplan-Meier. It's a lot of things. Here's the statement I would rather us learn. First of all, follow your protocols. If your protocol says give epi regardless, then you should do that. What I would like you to think is that until the career changes where they give you the type of moral impetus to make these decisions, it is your job to save everything you can. If you walk up and say, well, I'm pretty sure I can save this person's heart rate, enough epi and bicarb or whatever the case would be that your medic's giving, enough shocks will get a heart rate back, but I'm not so sure this person ever hawks, ever walks, or ever lives a normal life. My response to you would be, that is not your job. If they didn't sign a DNR that said, please don't do those things, then you should do everything that the law allows you to do to try to save whatever you can, even if you know they're never gonna talk again. That's not your job. One day it might be. And some medics would disagree with me, to which I would say, follow your protocol. I bet there is no protocol that says you shouldn't give epi. Currently all protocols are saying that because AHA is saying that. So, cardiac arrest, give epi. We'll talk in detail more about what this exactly lines up as. I don't want to talk a whole lot about ibuprofen bromide, though it will become more important to us to know what parasympatholytics or anticholinergics are and how it affects the parasympathetic nervous system. What's the major change here? If I'm giving ibuprofen bromide, you better be checking end-tidal. It's an airway medication, so show me. I used to say that end-tidal is how I see what my stethoscope can hear. If your patient has an airway issue, complication, concern, medication, end-tidal, or else, right? And in fact, we'll learn later about VQ mismatch and disassociation of the hemoglobin curve, about how you can sometimes see wheezing you can't hear. Or how you can see the difference between, is this wheeze bronchoconstriction or fluid? Because one of those means albuterol atropine and one of those does not. They might have wheezing and it'd be contraindicated to give albuterol. Does that register to anybody? Why might that be true? Why might it be contraindicated in a certain extent, or at least not beneficial to give albuterol to some people who are wheezing? You are close. What is albuterol? What's its mechanism of action? No. What's its class? Bronchodilator. Does it affect the sympathomimetic, right? Why would giving a sympathomimetic potentially and possibly be bad to a person with pulmonary edema? Possibly. What is it doing when I give you a sympathomimetic? What's another sympathomimetic we know? We know albuterol. What's another one? Epi. Why would a person have pulmonary edema that wasn't just fallen into a lake? Heart failure. Why would giving a sympathomimetic to a person with heart failure be a problem?
It's ramping everything up.
The problem is their heart, and now you're telling it to work harder. That has the potential to be dangerous. Now, do I think that you'll run into that issue in your career ever? I really don't. At most protocols, and I think this goes back to what Tony was asking, like, wait, so So how do I know when to give albuterol? Well, the answer to that is you need to have them at end tidal. That is the answer to that. It will tell you whether or not they have shark fin capnography or some type of bronchoconstriction. Listening will not be enough. The shortest, easiest answer to that question is that if you hear pulmonary edema, I'm not saying don't give albuterol and Atribin, but you should do it after nitro, after oxygen, after CPAP, after, oh, you're at the hospital now? Okay. So this is probably the most divisive topic in paramedicine. In fact, I wouldn't be surprised if half of our adjuncts are like, holy crap, why would you go albuterol? You're gonna kill them. That's not my message. My message is if you're gonna do albuterol, fluid can make you bronchospasm, so it can make you wheeze. My message to you is that if you're gonna give albuterol, it should be last line stuff. You should be doing a million other things first. Right. Need a break? Let's see, it's 10 after, let's call it 14 after, so we'll give it 4 minutes.
11 after.
Woo. Thanks for coming in, India, even though you weren't able to in the
We
early
love the M&Ms.
days like this. It can be so important.
Oh, lecture is a killer. I'm not half dead in here.
I'm already ready to go home.
Tiffany, I'm just gonna randomly text you different pages that you can calculate the dosages on.
Love it.
That'd be one. Oh, that's gonna be good too. That's gonna be the big one.
Mm.
You just said if you're in a, you know, your mother can put us in a situation where maternity what? I've been therapy. I was gonna say, you know, you need to, yeah. You definitely need to do this for all that. Yeah. Andy, cool. Near the station, right? There were a couple rocks at the station.
Oh, okay.
Therapy and health advice.
Record it, and then get it the same day.
That's pleasant, thank you.
I was like, I don't know these footsteps. I don't know this person. It was an idiot.
Do you ever do that? Do you ever like hyperfixate, like you lay there for a second, you're like footsteps, oh that's so and so.
Yeah.
I don't know that it's. I don't know that I hyperfixate necessarily, but I do try to like learn people's
Like footsteps.
sounds and scents. And
Yeah, I can do that
Like,
with
just
that's why
footsteps.
always with my
Yeah.
boys, I'm always like, don't
Sorry.
shuffle your feet, or everyone will know who you are. Like if you're ever trying to sneak, they're like, Dad, I don't want to sneak
Go
up
slow
on
and
anybody.
quiet.
But if you did, they would hear you come and pick your feet up.
I
Like,
work that with like steps
I want
and
that with
shoe-
every-
I'm not shoes,
Yeah.
cars.
Mhm.
I got to the
Yeah.
point where I could hear whose car pulls up, about the sound of how it pulls up and the way it sounds. I can tell who it is.
Yeah.
Because I So like my husband walking over there.
Yeah.
So he.
That's
so
what I
he
see.
was
Like,
when
he's
I
getting
came out
cat
of
was
the
telling
walk-in,
I
and I
would
go
pay
to
for
take
this.
stamps and I can tell that he was just.
Tomorrow
there
is
a
here
minute
today,
ago.
amazing
Take
cake
stamps.
sandwich, tomorrow's supposed to go.
Mine,
Oh.
yeah, my encouragement is that's the same thing. Like, you should wear light clothes so people don't know you were there. Like, you should have things that jingle in your pockets so they don't hear you, so they can't identify you. Don't, yeah. Yeah.
It's like, but I will laugh.
I think there was something else. Oh, here's another thing. Now, admittedly, I do not have many of these, right?
Yeah.
But you may also, just kind of like once around the room, just take a look at this. This is what we call an ampule. We've been largely drawing out of vials, okay? This is a glass ampule, and I wish I had more. I could only find 2. So any volunteers for desire to pop this sucker in? Yeah, cool. So keep passing it around just so everybody sees it before. What you do with these ampules is that you're going to want to flick it so that all the medication falls down, so none of it's kind of sitting in that cone head at the top. Because what we're about to do is literally just snap the glass in half with our hands. Maybe if you will put, yeah, no, I got this for that. What you do is you wrap it in gauze and then
I
click.
was just gonna.
Oh, yeah.
No. I mean, my guess is that they made some attempt at that, but what my point is that if you aren't currently handling the ampule, take a look. We have what's called a filtered straw. That's this little guy. Instead of it being a needle, it's just this soft plastic. You don't need to open it or anything.
Oh, yeah.
Actually, why don't you open yours? You got a soft plastic catheter over there, or what they call a filtered straw. See, because we're about to break this, we have to make sure that we don't just draw up little pieces of glass that fall into it. So this filtered straw has a mesh gauge in there, is what I want to say, like a mesh gate, so that you don't draw any glass up. So go ahead and prep your thing. We'll just draw up, say, like a 3 ml syringe or something, and attach our filtered straw. Now again, I only have one of these, so sorry. I would always say use as close to the max dose as you want. If we know that we're only going to draw up 1 ml, then you probably want to use a 3 ml. 3 ml is almost always what you're using. So, do you want to have one or what?
5?
I mean, you can. It doesn't super
I was
matter.
about to say,
but
here's a 3.
here's a free.
We got these.
Cool. So all you're going to do here is you're just going to, like I said, make sure that the fluid is all falling down to the bottom. And you're just going to take, I always use gauze because it just kind of prevents it, though I incidentally was usually wearing gloves. And all you're going to do, literally, is just, yep, boom. Now, that's glass and sharp, so be careful.
Just give me that.
Then you'll use your filtered straw.
Hey, that's glass and sharp.
Be careful.
Dangerous.
Glass and sharp.
Using his words against him.
And so I would not be surprised if you saw future questions that said something like, you've just drawn up 0.01 milligrams per kilogram through an ampule, da-da-da-da-da, what should you do? And you're like, oh, PEDS doses. And the answer is just make sure you use a filtered straw, or else you might push tiny pieces of glass inside of somebody.
And that's not what you want.
That's correct.
Just a
Yeah,
little bit.
or job security, you know?
Mm.
See, you know.
They get worse, they get
Cool.
more.
So you want to twist that off. It's not a sharp, but we'll be throwing it away. Boom, and now you have drawn that up and whatnot. So I'll take this from you. And yeah, I guess we can just hang on to it for now. So anyway, that's a glass ampule, whereas what we're drawing from, where we kind of snap the top here, these are what are called vials, and therefore you don't need a filtered straw, but you do if we're going through broken glass, right?
I love ampules. I know how to make your own ampule, by the way.
All right.
That's pretty cool. Welcome to chemistry, kids.
Yeah, man, that's from Pitch. Now, this doesn't have, this is holdover from our EMT class. I just kind of copied and pasted it. But this, I encountered this throughout your EMT class a lot, where I was referencing this to students all the time. Because somebody would say, like if I said, hey, your patient is having urticaria around their neck and difficulty breathing, what should you give? And some people will be like, oh man, albuterol, all these different things, and good meds, but there's an order there, right? And almost always, I need to add all of your meds to this. Where would you suspect, let's say, Toradol to exist? Like they need everything. They're trouble breathing, they've got wheals, they have wheezing, they're low sugar, and they also are in leg pain, and that would go
Third, 34th, maybe?
way back there, right? consider this. Let's say you have a patient who's complaining chest pain, and you suspect it's a myocardial infarction. Can you give aspirin? Can you give ketorolac? Which one would you rather give if you could only give one?
Aspirin.
See the priority I'm saying? So that's why I recommend when you sort these drugs that you sort them in this order, and I'll be happy to kind of update this. But is that you're like, okay, you got to ketorolac because this guy's got chest pain. You just passed 19, or we only had 16, but you passed 15 other drugs. Are you sure that this is the one you want? Because all of those other ones fell on higher priority, like oxygen, like aspirin, like nitro, these kind of things. Okay? So this isn't up to date, but it is something that I would talk about individually quite a bit, where somebody's like, well, I don't understand. Isn't Narcan completely appropriate? I'm like, it is, but he's got Strider. Epi's gonna fall before that, even if you thought maybe he was allergic to the heroin. Now, Epi's still where you're gonna wanna start, and oxygen more than most, right? You got a guy with difficulty breathing from a heart attack, which one takes priority, aspirin or oxygen? Oxygen, because it can help with the difficulty breathing long before the aspirin does, which is why it falls far higher on the list, in fact, almost in first place. Why would Epi be above oxygen?
Because if you're allergic to
Because we assess airway and ventilation before we assess respirations in a certain extent, right? If it's closed, it doesn't matter how much oxygen you're getting down there, I need to open it. And so Epi often will fall above in that case. And so oftentimes, I don't think Narcan would, because I'll be BBMing them. The metaphor of this list can kind of break down a little bit.
You said that's not updated.
It just doesn't have all of your meds. It's got all the EMT meds here.
You gonna put that on there?
Mm-hmm.
You gonna put that on there?
Yeah, I said my plan is to
Or is
update.
this in order, sort of, kind of?
That's in alphabetical order.
Oh, gotcha,
Yeah, I
okay.
hate that you did that, cause I have the order of the B ones memorized based on where they are in the paper, and you just switch through.
It would be very good for you if you just recreated your own and you're learning, so I'm glad you brought that up. Anyways, this is common for people to be like, but I thought this is the right med. I'm like, it is a good med, but it's not supposed to be given before these other life-saving interventions. Okay. I didn't have time to create one. Let's talk about, I'm just gonna kind of skip to it. I want to take a second. There's a big one like crystalloid solutions and dextrose is what we're going to be talking about Tuesday, because these are lectures unto themselves. But I want to take a second and start in on ondansetron or Zofran here. Now, Zofran is an anti-emetic, meaning so people don't throw up, emesis, vomit, right? There's a lot of mixed thoughts out there as far as should you give it for people who have already thrown up. I'm not trying to make this a hard thought process, so just know that if someone feels nauseated, I don't grade your PCRs, but nauseous is not what anyone means to say. Nauseous is how you describe a gas. Nauseated is the state of being nauseated, having nausea. I don't care, King doesn't care, but if I graded it, I would. Anyway, if somebody feels like they're gonna throw up or has thrown up, we're gonna give Zofran, okay? There's a lot of discussion in the world about how if they've already thrown up, or since technically ondansetron is a serotonin antagonist, if it's, for example, if you're having intracranial pressure, Zofran won't work because it largely affects serotonin stuff. And do we know this? If I have intracranial pressure building up, why am I vomiting? What's happening there? It's not a chemical imbalance. It's just literally pushing on my brainstem, which will cause a reflex to vomit. Well, this medication does nothing for that. I'm not trying to complicate things except for to say this. I'm very okay with you having a patient that is either nauseated, oh, I just don't feel good, I feel like I might throw up, or actively throwing up, you give Zofran. Okay? Whether this comes into play all the more so, is Zofran a life-saving medication?
No.
It's a trick question, actually.
Yeah, actually, that.
If you're dehydrated.
If you're dehydrated, very good, I wasn't thinking that, but that's a good answer, right? Fluid out, fluid in. Very good answer. There's another instance, it's relating to trauma, or in our interventions for traumatic patients where it might be a preemptively life-saving intervention.
Oh, for
If
blood
it
pressure.
went to the aspirin.
Okay, I also didn't think of that. You're doing great. Right? If essentially if the act of convulsing for vomiting would cause us a problem, like they were in a pneumo or they had broken ribs or throat, all good answers. You can just teach next Tuesday, it'll be fine. Anyway, the point is that mostly what I was going for, even though all of this is true, is aspiration backboard.
Yeah.
I get a guy on a backboard and they're like, man, I just feel so sick, like I'm gonna throw up. Zofran.
Be like,
Let's
here.
preemptively do that. Now, ondansetron or Zofran has a paradoxical effect if you push it too fast. What does that mean? It's the opposite. You push it too fast, they throw up. So the question comes, how fast is slow IV push? How fast should I be pushing this?
Just like a nice pace.
Number 37.
Yeah, I don't know what the number is. I'm sure there is one in your book. I don't know it.
Just like a.
The best way, I always taught this to people, I'm not gonna grab your arm here, is I would just say, okay, do you feel me squeezing you? Right, that's how fast I would push it. Just about, I always say about 20 seconds, but it probably takes me 10. And I've never had anybody throw up because of it. So I would just say, just take your time with it.
Is this the one where you push it too fast and you can give them tinnitus too?
Yeah, sure.
Oh.
Yeah. And in fact, I might come to really appreciate you having brought that up. I swear I saw that on the registry. I think it was a medic registry, but I swear I saw it on a registry tonight. I'll look into it more before I teach it.
This one's not in Georgia scope, right?
It is not in your scope in Georgia, meaning we will be giving it in class, but not in clinicals. Or at least, and most importantly, not documenting that, right?
In your notes it says information lab. Is that what you mean?
That is a mistake. It's just a copy-paste error, thank you.
What is?
The fact that this said, I mean, it's still true, it's just not relevant for Zofran.
Oh.
Actually, you can give anything fat-soluble through the nose. It might incidentally and accidentally be true, but I don't know that. The point here is this, the Zofran note is not really relevant because we don't have an IM dose for it, but you probably can. In fact, I would also encourage you probably not to do this IM. Why?
Maybe take homes, by the time it works, so, I don't know.
Yes, what were you saying? What did you say? Someone missed?
Well, when you give something intranasally, it's.
Oh, sorry,
so that-
intramuscularly is what I'm talking about.
Oh, I thought, you said IM?
Yeah, sorry.
I'm sorry,
Mama,
I thought
mama,
I heard IM.
No, no worries. One of my favorite jokes that never comes up is when you're trying to differentiate N and M, and you say it's M as in Mancy. Like, that's not helpful at all. I love that joke. I've never been able to use it, but anyway. So I don't. For much like Trinity said, it's like I got a guy. We're 20 minutes from the hospital. I'm gonna give him an IM injection of Zofran to stop his vomiting 20 minutes from now. That just makes no sense to me. So I very rarely did that. I would encourage you, in fact, to give this IV or probably not at all. But you wouldn't be wrong to say, well, we can't establish an IV. I'm going to give it IM. In fact, you can technically drink the stuff. You can just crack a vial, spike it open, and drink it. It's not in your scope, so therefore you can't. But it does work. It tastes horrible, but it works.
Oh, worse.
Why is it not in our school?
It's not in your scope to drink it.
No,
Right
I
on
mean,
Ames.
oh.
Huh?
Is it Ames?
No.
That's true, yes.
No.
They have
Tablets.
Well, I don't know that actually. I mean, I know that I know there's PO Zofran, and that I don't think there's much of a difference outside of its physicality. I don't think the molecular difference is much.
But Georgia is
It's
one of
funny
those
the
states that's like,
dysrhythmia part,
no,
because like my
and
friend
it's
has
like,
heart
why?
problems, but she also has
it's
like
Zofran.
a phobia of throwing up. So anytime she gets any drugs, she tells them she's nauseous, so she will get more Zofran.
Sure.
And she takes it all the time.
So here's what I want to say in regards to this. This says prolonged cardiac refractory period, or rather prolonged QT intervals. In this class, to determine QT intervals, you need, not in this class, in general, to determine QT intervals, you have to do a 12-lead. 12-lead interpretation is not part of our scope. Here's what I want from you, is for you to say, okay, I'm gonna go through my med check with ondansetron or Zofran. What's my indication? My patient is nauseated. Great. I've got the right dose. I'm gonna give 4 milligrams. I'm gonna do an IV, and that'll be that. Sounds good. Contraindications. Okay. Sir, are you allergic to Zofran? No, I'm not. And then to ask the question, do you have any history of dysrhythmias or irregular heart rates? Which is what dysrhythmia means, right? And if he's like, no issues with my heart, then you give it. The real question is do you have a prolonged cardiac refractory period? Is your QT interval wide? But we can't monitor those things, so I don't see a point in asking it. I am okay with you saying, before you give Zofran, and in fact you would be wrong if you didn't ask, sir, have you ever had any problems with your heart, like an irregular heart rate or dysrhythmias? And if he says, actually, yeah, I have X. Yes, I have a dysrhythmia problem. Then do not give Zofran. It is mostly not a life-saving intervention. And we have found in very rare cases that it can make dysrhythmias worse. Very, very specific dysrhythmias that we can't test for without 12 leads, so we just play it on the safe side. If it were aspirin that did that, I'd probably let it roll. This is not aspirin. So again, part of the contraindications are, sir, do you have any history of dysrhythmia or irregular heart rates? Because some people don't know what that word means. Okay? Truth be told, we give far less. Anybody have any idea what the IV dose for Zofran? Do you know what the IV dose for Zofran's loading dose in the hospital is? I think it's around 30. So 2 things. Number 1, it's only very rare instances that Zofran is making it worse, and we have no instances of 4 milligrams doing it. Usually it's 30 to 50 milligrams causing it. So we're just never in danger of that. Now, as a paramedic, you should technically, by definition, put every person with nausea, vomiting on a 12 lead. First of all, heart attacks cause nausea, vomiting, and if you're giving Zofran, it can cause QT prolongation, so therefore do a 12 lead. But we don't have that, and we do have Zofran, so we just ask about dysrhythmias. Any questions there?
Do medics give the same amount, or are they able to give?
They
enough
give the
for-
same amount. This is a medic dosing, if you will. India?
Might be a dumb question for the cardiac refractory period, because I don't really understand it at the moment. How would that affect blood pressure?
So, do you remember my toilet analogy? Like, you take a big leak, you flush the toilet, and you're like, whoa, that wasn't enough, I gotta take another leak. And you go to flush it, and it's just not working because it has to refill. Your heart works the same way over seconds, right? So if I have my heart rate is squeezing, and before I let it refill, I squeeze again, that could lead to a dysrhythmia. I need to time it out appropriately. And Zofran, in rare cases, causes that refractory period, or the amount of time to fill up, to extend, which makes us more likely that the heart rate will start again at the wrong moment. It would be kind of like me shocking you at the wrong time. It'd be like, and then cause a dysrhythmia. But that's a good question though. Where do you suppose that we're giving this? You remember our long patient assessment sheet? We've got scene size up, we've got primary, secondary. Where are we giving Zofran?
Secondary.
Probably, right? It's probably very rarely, because there are certain meds. What are some meds that we might get in the ABCs or in the primary? Oxygen is a good one.
Epi.
Possibly aspirin. Epi is another great one. Narcan for sure, right? These are things that, I want to complete my ABC because you don't want to make sure that you're giving oxygen to a dude on a cannula that needs CPR, okay? But you might still give it as soon as you possibly can. Zofran is, say it again?
Glucose or dextrose.
Glucose or dextrose. Once you get through ABCs, boom. In that little chunk there where we got CABs would be things like dextrose and the like. Sure, I can see that for sure. I can see that for sure. That's Zofran. We are almost done. Let me see. We need to talk about glucagon. Gluca where? Got a handful of meds, kids. This is gonna be fun. Okay, maybe I'll touch a little bit on some of these interventions. I'm starting to think more and more I should not call these drug cards, I should call them intervention cards, and then just list all the things you can do. Because when I see people struggle with like CPAP, I'm like, man, they should really be viewing it like it's a drug. What are the indications? What are the contraindications? And the more I think about it, the more I think like a lot of things are like that. But anyway, let's pull up glucagon, essentially. All right. So glucagon is what we call an endogenous chemical. What that means is you make it,
Yeah.
right? It's one of the rare few confrontational moments I had in my medic class. I would leave one medic class and go to another that was more my interest in speed, I suppose. But there was some fellows in my medic class that were pretty frustrated, I guess. They didn't like that I asked questions a lot, and my response was, I paid for this, and I'm smarter than you. And if I don't know it, then you probably need to hear it. So shut up, right? I would later talk to both of those gentlemen in the hall and say, hey, do we have something we need to sort out? This is my education. If you want to fight or whatever you need to do, let's do that now. One guy was like, oh, okay, and the other guy was like, So anyway, the one guy I explained it to who was confused about the endogenous, I said, for example, exogenous versus endogenous. One is inside of you, essentially, that you create, and one is an outside force. I said, if I come over there and I stab you to death, you are dying to an exogenous force. A knife that is not of you is now entering your body. Anyway, we worked it out by me leaving that class. But all the same, glucagon is made by your pancreas, right? So this largely probably drawn from an animal. I don't know where. It's probably not people, but it's an endogenous chemical, a hormone specifically. In short, if you remember, we store sugar. Insulin helps us get our sugar into our cells so that we can live, so that we can use our muscles. And when we have too much, right, like let's say I ate a Snickers bar and all I did was sit here all day, my body would say, you only needed half of that Snickers bar, so I'm gonna go ahead and store the rest of it. It's how we gain weight. Simply that. Ask anybody that tries to get into bodybuilding, how do they get bigger? By using their muscles and increasing their caloric intake. And they say, well, good calories, bad calories. No, calories are calories. They're all lightning bolts.
Doesn't matter.
You eat a ton of Skittles or a ton of chicken, like those are all calories. They all count the same way. You will get bigger. If you eat more than you use, you will get bigger. If you eat less than you use, you will get smaller. It's that simple outside of thyroid conditions and stuff like that. But anyway, the point is that if all I did was one half of a Snickers bar worth of moving and talking and energy today, it would store the other half. Where does it store it?
Fat.
Fat and liver, right? Well, if tomorrow I eat no Snickers and I still need to do half a Snickers worth of effort, glucagon will be released to pull it out of my liver and fat. Who is glucagon dangerous for? Tony, what do you got?
Thinking hyperglycemic patients.
Hyperglycemic?
Yeah.
It would be contraindicated, and so I would agree that that's not good. Like, I don't need to add more sugar if your sugar's too high. I'm okay with that. I'm okay with that. You're about to give glucagon, and I say, whoa, no, dude. Who is that person? Where does glucagon, the natural occurring hormone, where is it pulling sugar out of? Liver, fat. So who?
People who don't have fat.
People who don't have much fat or any liver stores. These are tiny little babies. These are emaciated patients. This is a 70-year-old man, thin as a rail in the basement. He's hypoglycemic. It's like, wait, glucagon pulls from your stores. If you ain't got no stores, this could be dangerous.
Time to give you some juice.
Right.
What about,
So
would it also be like liver, patients with liver
it can be.
issues?
Now, here's what I would say. Don't get too lost. The only contraindication is that hypersensitivity or an allergic reaction to the medication, which it's endogenous, so how does that happen? It's possible. The point I'm making here is the only contraindication is that, which I say that to encourage you, because what would we give for two hypoglycemic patients? Say it again? Dextrose, that's a good AEMT answer. Dextrose, right? Oral glucose is also a very good answer. So the point I'm making here is that our indication is hypoglycemia when we're unable to establish an IV. Because if you are able to establish an IV, I would rather introduce carbohydrates to you than force your body to use the ones that it already has. My conversations with this, I very often do refusals on hypoglycemic patients. There's no medical mystery. What are the only two reasons a person's sugar would be low? Too much insulin or too little sugar, right? So one of two things happened. They either didn't eat enough food or took too much more insulin than they ate food for.
Yeah.
Well, okay. So if it's very common for someone to wake up and be like, oh, I'll eat breakfast later, I'm gonna take my insulin now, forget to eat breakfast, and then go down. And so I very often will just say, well, let's just start up a line, run in some dextrose. They're probably gonna wake up and say, I don't wanna go. And I'd rather have that conversation here in their house than 2 miles down the road, right? Super common. And I'm okay with that. I'm okay with saying, hey, make sure you eat heavy carbs and some protein, meaning we want some peanut butter and jelly sandwiches and so on and so forth. You will definitely dip back down if you've taken long-acting insulin like Lantus and all these kind of things. Glucagon is a different conversation. If I can't get an IV on you and I give you intramuscular glucagon, which is usually done with gluteus, by the way, just because it's a large muscle that can absorb a lot. If I'm giving you glucagon, when they wake up and say, I don't want to go to the hospital, I say, hey, I get it. And ordinarily, I'd be okay with that. Today is different. I gave you glucagon. That is not sugar, which means if I leave and you don't eat, you might die. Today is different. I'm sorry I couldn't get an IV on you. Please go to the hospital now. That's a different conversation in my mind, okay? I told myself I would go my whole career without giving glucagon because I would get an IV and I'd given it twice. It happens. It is a good medication. I wouldn't call it dangerous. In fact, the contraindications are only allergic reaction or hypersensitivity, right? So don't be afraid of it. However, I really want you to think it's last resort. I really want you to be trying hard for dextrose. 3 lines, no go. Guess we have to do glucagon. What we shouldn't be is like, well, I am so much easier. Let's just give that. No. So therefore, stop dying. You're choking, knock it off.
Children can't die, no.
All right.
Somebody joking
Someone give me some dogs.
Ineffective and emaciated patient. All right, so let's take a second here and just crack open. Does everybody have a glucagon thing? Oh, you have the weird one. I've got plenty of them, but I just kind of want to expose people to different situations. Go. You tell me. So I'm not teaching you that, even though I do that. I will say, as a medic, yeah, that's what the syringe is. The shortest answer to why, as a medic, I didn't do that is because glucagon isn't dangerous and is more effective than me doing oral glucose and waiting. So the answer to your question is that it should go if you are contraindicated for oral glucose, meaning can't swallow unresponsive, you should do dextrose. Can't do dextrose, you should do glucagon. But it is a good thought process. No, but you should think in that direction. Like, you should think least invasive to most. If a person is a candidate for oral glucose and you do dextrose, you are in the wrong, even as an AEMT. And in fact, we will likely have scenarios or test questions coming where, what should you do? And the answer will be oral glucose, because there's no indication that they're not a candidate for it. So glucagon is a suspension. What do I want to say? Earlier, I said, oh, I forget how it breaks down. Here's what I'm sure of. The oral acetaminophen is a syrup. And a syrup is a suspension with sugar in it. This is just essentially a separate solution. Is that right? Solvent? Yeah. Because what we have is both a solvent and a solute that have to be what they call reconstituted. Okay? So what that means is we need to take our solid. Now we won't do this just yet because I think you can envision it, and maybe we'll save this for later, but how these kits come is they come with the powder and they come with the liquid, and you're gonna have to reconstitute it, which means you're gonna inject the saline into the dry one and then shake it up real good. This one, they're probably not supposed to be in a solid piece, though maybe they are.
Because it looks like they're in a tab.
Yeah, it probably just dissolves easily. I feel like I've only ever seen powders, so I don't know if this is time or what, but
Kind of reminds me of
it's possible.
pills.
Or it's possible that I just somehow, like I said, I gave it twice. Well, maybe more than that. You can actually give it for beta blocker overdose as paramedics, but that's, it's neither here nor there. You just need like 30 of these things. Anyway, what you're doing, they usually come with either a separate syringe or just a normal sterile water mix, and you just mix them up, you shake it real good, and then you draw the whole thing up and you inject it. But you should know that it comes as a powder that needs to be reconstituted, and that's what glucagon is. And then you'll be administering it intramuscularly. It needs to be absorbed through the muscle. You can technically give it IV, and in fact, it is in your scope, and so you shouldn't think it crazy if you see a registry question and the answer is IV glucagon. I really don't think that'll be the answer. However, they're also not going to give you a bunch of right answers. They're not going to give you IV glucagon, which is true, and then other right answers. That's not going to happen. So you should hopefully be able to say it's not this, this, or this. I guess it is IV glucagon. Why do I say not even teach you IV glucagon?
Because if you have an IV, you can dextrose.
Blammo, right? If you have an IV, you should just be giving dextrose. Because I would rather put sugar in you than take the sugar out of you, right? Very good. Okay. We'll finish here at 4, so just a little bit more time. We've gone over Ondansetron, we've gone over epi, we've talked about mixing epi, we've got our hands on some of this stuff. There's a lot to think about now, right? There's partly we wanted to assess a patient, do life-saving interventions, but now suddenly our secondary assessment becomes more involved. We've got a lot of questions coming, which is, where do I do a supraglottic? Where do I start an IV? And that answer changes based on your patient's requirements. I mean, is dextrose a life-saving intervention?
Can be.
Certainly is, right? What do you need more than anything from your blood? You need oxygen and
Sugar.
you can die from lack of sugar. It is a life-saving intervention, which means it probably falls way up. So in that case, in a hypoglycemic patient, once I determine I don't need to bag you or do CPR, I'm probably immediately establishing IV access and running dextrose right there, on scene, in the primary, right? However, things like, oh, I just got a kidney pain or something like that, and so I do want to establish an IV, and I do want to give ketorolac or acetaminophen or whatever the case is, well, then the IV falls far lower, which means you're not going to see places like do IV here, do IV there. You need to know when to do an IV, whether it's appropriate or not, right? And what it ultimately means, moving from EMT to AEMT, is now your secondary has more going on, is usually what it means. It's just like, and it's not just like, I reassess vitals and I'm going to call in a radio report. It's like, nope, we're going to probably see our, like practicals are going to switch. It'll say like, you have 15 minutes to complete this scenario. You don't stop until 15 minutes has elapsed. So if you finish the scenario in 9 minutes, you sit there for 6 minutes. What that means is essentially is that you'll be going through it at your pace and doing your things. I found that we were having a lot of issues where we're just like, anyway, I want to run the call and secondary stuff. No, dude, you got space in there. You should utilize that space. You should reassess vital signs. You're moving too quickly. You should use what you got and stuff. Do you see that hand somewhere?
I'm curious, if you have a patient, low blood sugar, and give them dextrose, they want to center food and everything,
Yep.
would you offer to remove the IV, leave it with them?
Sure. That's a good question. Yeah, I'm actually really glad you brought that up. Anything I came with leaves with me.
You put it on the report too, took it out.
Yep, 100% you will. I have long since thought about an agency that just starts IV for crack addicts and stuff because I'm like, they're gonna do it anyways. I might as well give them a fresh, clean line that he don't get infected, and I'm really good at it, and you know, I mean, blah, blah, blah. But the point is like, why can you walk out of here, go into Walmart, and legally start an IV on someone? It's an easier question because, of course, you're a student, you don't have a license. But could I, as a paramedic, do it?
No.
Why not?
Because you're not getting paid for it.
That's correct, right? So essentially, you're only doing these IVs because the medical director approved it, and he only approved it in the case of correcting an emergency. And once that's done, it's time to be done with that. In fact, there are plenty of times where somebody's like, "Hey, I don't want to go to the hospital anymore. Please pull over." I did albuterol, Atrovent, Solumedrol, oxygen, IV, maybe 2, and I'm like, okay, and you peel all that stuff off, you take out the INT, you tape them up. So excellent question, and yes, and especially for dextrose, all the time. I'm just like, I'll just be holding it while they wake up. I'll be like, hey, you got an IV here, easy, 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 easy. And then before I leave, when I'm sure that's going to be a refusal, I'm like, okay, let me take that IV out of here now. Excellent question, for sure. And I will say, especially now that we have access to so many medications, my philosophy has always been, I will do everything you let me do. Right? Guy can't breathe, I give him albuterol, I give him Solumedrol. He's like, oh, my leg hurts, I give him ketorolac, I give him all these different things, and he's just like, look, I don't want to go anymore. You fixed me. I'll be like, look, just had a bunch of stuff introduced into your system. We don't know how that's going to affect you. I really recommend that since we open the can, we eat the whole thing. But at the end of the day, you're not altered. I'm not a cop. You're not a criminal. So you can do whatever you want. So if they say beforehand, I don't want to go to the hospital, but I could really use some albuterol and Atrovent. I'm like, dude, I will do everything you let me do until you won't, as far as legally and appropriately. So. Okay, last thing, I just want to kind of re-emphasize or a brief expression on
You do.
end type. So, oh yeah, that's right, because I was going to like set lines up and drain it out of a bag and stuff, but we'll be doing that Tuesday, so that's okay. Lastly, I just want to kind of talk about end title. We'll get into this more, and we've got a week or so before we start doing scenarios, because we'll be doing the IV stuff. But again, end title is your bread and butter now, right? While we're assessing airway, we definitely want to be just put it. I'm okay with it falls weird in testing world, where if you were like, what's their airway like? I'm gonna go ahead and put them on end title, then I'm gonna check for a pulse. That's weird, right? So technically, end title should probably fall in the CAB bit. Like if you're listening to lung sounds, then do capnography, let's say. My point is it should exist very soon, because you're gonna wanna be able to differentiate some of these things early. Now end title, it looks, I don't have a picture just yet, I guess I could Google it, but, well, I'll do just that. Okay, here's the first one. Can we all? Okay. This is inline. This is like you've put in an eye gel, or the patient's been intubated, or you have a BVM mask. Then you attach this to the mask, and then attach the BVM to it, and this is inline end tidal, and it'll give you waveform. And of course, it's breathing out. It's breathing out the CO2. And then the other type, I don't know that it's more common necessarily, but on your conscious patients, it looks just like a nasal cannula here, except for it's got a paddle. Like that it's, I believe it's the paddle that's detecting your CO2. I've heard differently, but I believe it's that. So it's just a cannula, and you put it on just like a cannula, except for one thing. I can touch your face, but, well, I'll touch mine so that way you can see it. Let's do it together. Okay. So the point is that I see it all the time where somebody's like, oh, they're having respiratory distress. They put them on nasal capnography, and it's got that little paddle there. It's got like this little paddle here that's kind of hanging off, and they're like, dude, their capnography is like 0. I'm like, okay, 0 is death. That means they're not breathing, and so I'll just do this. And they're like, there it is, it's fine now. I'm like, yeah.
It's like, that
Right.
sounds about right.
Yeah, I mean, here's the thing to remember. What I'm not saying is we now put capnography on every cardiac arrest because it is the gold standard for resuscitation, or ROSC, okay? Nobody comes back from less than 10. If your capnography is less than 10, you're dead, and you stay dead. It is like watching somebody get decapitated. That's it. Now, it's not initially. Like, if I put you on and you're at a 9, that doesn't mean I'm like, oh, call it 9. No, we want to do some work, give some epi, do some cardiac arrest, whatever. But if you're trending down and you go below 9, you don't come back from that. So there's been plenty of times, I'm like 17 minutes in, I'm working an arrest, and I watch it 10, 9, 8, or I'm like, okay, let's call it. No one comes back from that. That is cellular cessation. Their gas is no longer exchanging despite how much oxygen you put in. They are dead. If I'm bagging them, they're at 11, they're at 12, whatever the case is. I'm like, hey, slow down your bagging a little bit. It should really kick up. Maybe you're bagging too fast, and it doesn't. And okay, let's go ahead. Let's go with our second round of epi. Bam, doing a CPR, and suddenly that 11's like, bam, 16, 19, 20. It's like, yo, check a pulse. That person is alive now. The only reason it would spike is if they're coming back to life. Okay. So very often, will I see them be like, I don't know, it's like a 4. I'm like, 4 is what this table would read. That they're talking to us, and so very often am I like, right? Where this will come into play is in scenarios where your mannequin will be like, you're running an IV, but it's not flowing. And you're like, I don't understand. Why is it not flowing? What's wrong with their arm? What's wrong with the meds? And it's like, oh, you left the tourniquet on. You're like, dope. So you have to pull the tourniquet. And so too will this. Your capnography reads 0. And just like the dope mechanic, essentially, for intubation or for eye gels, I'm thinking, okay, I need to check my equipment first. right? And this will just be pushing down and typing in that regard. So. Alrighty, no. Can I actually look that?
It's
Um,
gone now.
Do me a favor then. Is there anything else I want to talk about in favor? I don't think so. I think it's good enough. Do me a favor and try to, I guess, recap everything.